So this section I want to talk about osteology, and that's the study of bones. And in this, we're going to talk about the function of bones, the divisions of the skeleton. We've essentially got two types of bones: general bony features, and that would be the portions of the bones and the things that come off of bones or indentation in bones. We'll talk a little bit about bony development, not a lot, but we'll talk a little bit about it. We'll talk about classifications of bones and types of fractures. So the functions of the bones are right at the top. We've got attachment for muscles, which provide the mechanical basis for movement. So they may not attach directly to the bones. The muscles may not attach directly to the bones, but they attach through ligaments and tendons, and that is what gives us our means for movement. So anytime you see a feature on a bone that's a big kind of a projection off of a bone, chances are there's a ligament or a tendon that attaches there, and it pulls on that so that you can move. So you've got muscles with ligaments and tendons come down to your knee, and they just help you move in all different directions. Also provide protection for internal organs, like your ribs provide protection for the um, the lungs and the heart and the great vessels in the mediastinum. Pelvis provides the same protection for the lower portion of the abdominal cavity. Also provides support for the frame so that we can stand up, sit up, those sort of things. It's also storage for calcium, phosphorus, and just mineralization. And whenever we lose that mineralization through disease processes like osteoporosis and rheumatoid arthritis, we're prone to fractures. So, and that's what we would refer to as pathological fracture. Also, though, we have production of red and white blood cells inside the marrow. And the type of marrow that produces the majority of our red and white blood cells will be our red marrow, which is found throughout the body, but especially in kids. It's in all of bones pretty much. As we mature in age and we need less blood because we're not growing anymore, then a lot of that turns to yellow marrow, which is basically fatty marrow. So there's 206 bones typically in the body. Sometimes we may have a little bit more than that. Some examples of where we may see more than 206 bones are once in a while a patient will have what we refer to as cervical ribs. You should only have ribs on your thoracic vertebra, but on C7, just once in a while, somebody will have these little bitty short ribs that they don't even know that they have. And sometimes it's what we refer to as an incidental finding. They have neck pain because of something else, or maybe those ribs are compressing a nerve, and that's what's actually causing their pain. So that's what we refer to as cervical ribs. Sometimes we have a patient with 6 lumbar vertebrae. Sometimes we have a patient with 4 lumbar vertebrae. Sometimes we have a patient who has what we refer to as accessory bones in the mouth. If somebody clenches their teeth, they can grow an accessory bone. You have some patients who will have accessory bones behind the ankle. Of all of those, I've never seen anybody with cervical ribs with 4 lumbar or 6 lumbar vertebrae. I have seen patients with the bone behind the ankle though. But it's divided into 2 main groups. That will be the axial skeleton and the appendicular skeleton. And the axial skeleton is what's coming straight down the middle. So that's what we refer to as the trunk, as opposed to the appendicular skeleton is where your extremities lie. So it looks like that. The blue is your axial skeleton, as opposed to that cream color would be your appendicular skeleton. On the bones, the construction of the bones, we've got compact bones, we have spongy bone. That's not 2 different types of bone, that's within a single bone. So the compact bone is the outer portion. It's got a cover on it that we refer to as the periosteum, but it's the compact bone, it's the outside, it's what you see. But on the inside, you've also got a bone type of bone. It's more like a spongy bone. And in it, we have kind of like a spider web lattice structure that reaches across the bone, and it's sometimes what we refer to as cancellous bone. The compact bone we refer to as cortical bone because it's on the cortex of the bone. My voice is kind of fading in and out, so forgive that. So the trabecula inside of the bone is where that bone marrow is found. So red bone marrow produces red and white cells. We talked about that. Yellow marrow becomes fat, or red marrow becomes yellow marrow, and it becomes fat. And it's found inside of the bone, especially in the medullary cavity. So if we were to take this femur and cut it in half, you could see kind of down inside, but what you would be looking at is the yellow marrow. But if that yellow marrow was gone, then what you would have is just an empty hole. And you've probably seen this on like ham shank bones. Um, so it's just a hollow area inside the bone is what the medullary cavity is. And sometimes we use that medullary cavity to fix bones. So especially in really long bones like the femur, if the patient breaks a femur mid-shaft, in a lot of cases, we'll put a rod that goes all the way down through the medullary cavity in order to repair the bone. So that outer layer that I talked about before is what we refer to as periosteum. You also have a layer on the inside, and that's what we refer to as the endosteum. So I like to use word association where I can. Endosteum is inside, so in, as opposed to the periosteum is on the outside. So ossification is just the development of bones, and it begins second month of embryonic life. And there's two different processes, and that's intermembranous and endochondral development. So, and that's really pretty much everything that, for our purposes, that you're going to need to know about that. So I'm going to go on through into bony development after birth. So um, we have primary and secondary ossification in bony growth in kids. So our primary ossification is in the shaft of the bones or in the body of the bones, and then our secondary ossification is what I always, when I was in school, what I thought of as primary was growth and length, but that is at the growth plates, and that's what we refer to as the epiphyseal plates, and that's really your secondary centers of ossification. So the middle of the bone is primary, secondary is at both ends in the growth plates. So our classifications of bones, we've got long bones, and what you'll find in anatomy and in medicine is if you have a distinction like long, you'll have another distinction like short. Now, it doesn't always wash out that way, but in a lot of cases it does. So we have long bones, we have short bones, we have flat bones, irregular, and sesamoid bones. We'll talk about each one of those. So long bones are any kind of bone that's kind of cylinder in shape, like the femur. It's long and skinny, but not all of your long bones are long. But where you have long bones, most obvious would be in your femur, in your lower leg, your tib fib, in your upper arm, in your humerus, and then in your forearm, which is your radius nulli. But also your finger bones are considered long bones. Each individual portion of your finger bone is considered long bone, even though the distal end of your index finger may only be an inch and a half long, it's still considered long bone because it's tubular in shape. So anything that's shaped like a tube is going to be considered long bone. So again, you've got long bones, so you've got short bones as well. And a short bone is, in a lot of cases, it's kind of a square, cubey looking bone. And where you see those will be in your wrist bones. That's what we refer to as our carpal bones. So in your hand, what you've got is you've got individual phalanx making up the digit, and then you've got metacarpal bones making up the palm of the hand. And then in the wrist, you've got what we refer to as carpal bones. And you've got 8 of them in a space of about that big. So 8 individual carpal bones, and they're referred to as your short bones. Also, though, you find short bones in the feet and ankles too. Flat bones are they're kind of thin bones, and we don't have round bones in contrast to flat bones, but we have flat bones, and they're relatively thin, but they've got an outer portion and an inner portion that are very similar, and then you've got inside of that what we refer to as diplo. Then your irregular bones are they're not irregular because they're unique, really. You've got, again, 7 cervical vertebrae, and then you've got 12 thoracic vertebrae and 5 lumbar vertebrae. And there's some differences between those, but in large part, they're similar in their construction. So you got a lot of them. It's not that they're very unique. There's quite a bit of them. They just don't fit into any of the other categories. Plus, they've got a lot of features you don't see anywhere else. You got, like in a vertebrae, you got a body, then you got a ring behind that with a hole, and then you got projections off of that. So you got a lot of different features in your vertebra. But you also find some irregular bones in the facial bones and some of the cranial bones. And we won't talk about those until next semester. And sesamoid bones, not all of them are very small, so most of them are, but you've also got 2 big ones, and that would be your kneecaps. So your patella is the largest sesamoid bone, but they're kind of oval and flat. And they're not a flat bone, but they are kind of flat and oval in shape. So they're shaped kind of like a sesame seed. Let's skip past all that and get to arthrology. And we're not going to talk about every type of joint. We're just going to hit on the ones that we need to understand. So you've got basically 2 different types of joints, functional and structural. So a functional joint is what you would be thinking of whenever you think of a joint. So if it moves, that would be a functional joint, as opposed to a structural joint would be a joint that doesn't move. It's still a joint, 2 bones coming together, so it's still a joint, but they don't move, so they just give you structure. So you have 3 subdivisions based on mobility. You got synarthrosis, which are immovable, and we'll talk about those here in a minute. You've got amphiarthrosis, which are slightly movable. We don't have a whole lot of those to talk about. And then you've got diarthrosis, and those are freely movable. Those are, again, the ones that you tend to think of whenever you think of a joint. It moves, it's a joint. So based on connective tissue, you have fibrous, cartilaginous, and synovial joints. And the synovial joints, again, are the ones that move a lot. So we'll talk more about those than anything else. So in fibrous joints, what we have are 3 different types. Again, we have a syndesmosis, a suture, and a gomphosis. What we're most familiar with is a symphysis. So, excuse me, when you're born, your skull bones are not fused together. So they're individual bones, and you can see the soft spots or fontanelles in the front and the back of the skull. Sometimes you can actually visualize a soft spot in the front of the skull, or not really front, but on top of the skull. So that would be where the frontal bone and the 2 parietal bones should join together, is what that soft spot is. So once the child starts to grow, and later in adolescence, those will fuse together and become sutures. So they're fused bones is what they are. Gomphosis are specific to the teeth, so we don't do teeth a whole lot, so we're not going to talk about that beyond that. But a syndesmosis is something that's kind of interesting. So some of your bones are they articulate with each other, they communicate with each other, they touch each other, but they don't have any kind of inherent stability between them. Where we see a syndesmosis is in the tib fib. So you have 2 bones in your lower leg. You have your tibia and your fibula. They're parallel to each other, but they're very long, and they don't really have anything holding them together. And a syndesmosis, the way I like to describe syndesmosis is that you've got this connective tissue that's holding those two bones together tightly so that they kind of move as a single unit. Almost like a compression sock. You got a compression sock pulled up over those two bones. And sometimes when a patient breaks their ankle, it destroys that syndesmosis and they have to repair that. Not just the bone, but they have to reestablish that syndesmosis. So it provides stability in those, in the ankle. So we just talked about all three of those. We're going to go right past them. A symphysis is a cartilaginous joint. And where we see a symphysis and speak of a symphysis quite a bit is in the symphysis pubis. So in your pelvic bones, what you have are these two great big bones, and that's the upper portion that you think of whenever you are looking at a pelvis. But if you look at the bottom of the pelvis, what you see are these two bones that kind of come together in the front, and they form a hole. That hole is what we refer to as obturator foramen. But where those two bones come together, and it might not even look like they touch, that is what we refer to as our symphysis pubis. And there's a little cartilaginous joint in between there. And the purpose for that, along with the bones of the skull not being fused together at birth, is that the skull can collapse a little bit and the symphysis pubis can spread out a little bit, and that makes more room in the birthing canal and a smaller, anatomy to pass through the birthing canal at birth. So that's a symphysis. Then your synovial joints permit a lot of motion, freely movable, complex joints. They have a capsule enclosed by a capsule, got some fluid in there, with a meniscus maybe, and a bursa. So we've got a number of different types of those, and we're going to take a look at a few of those. We're not going to spend just a whole lot of time on those. So gliding joint, these are your wrist bones. So the hand is here, and the radius is here, and the ulna is there. So they're tied together, but they're not really fused, so that they can move just a little bit in between each one. I wish on this hinge joint they would have used something besides the elbow. I wish they'd have used the knee. Excuse me, used the knee. And the reason for that is because of the knee, you truly just have, really one motion. In the elbow, it is a hinge joint, but at the same time, you've got some rotational motion there as well. So it's not just a hinge joint, but it's also a pivot joint, which is the next one. A pivot joint, what you're seeing here is the articulation between the first and second cervical vertebra. So on the bottom of the skull, these two pads right here articulate with these two things right here. So occipital condyles. And what we have here is C1, and we refer to C1 as the Atlas. So in Greek mythology, Atlas has carried the world around. So this thing is carrying your head around. And this is what we refer to as the axis. So axis, kind of like an axle, you got rotation, right? So the head is sitting on top of these two little pads here. And as we rotate the head, what's happening is Atlas is swiveling or pivoting on the axis. So most of your head movement occurs right there. You don't have a whole lot of rotation. You shouldn't have a whole lot of rotation at any other joint. An ellipsoid joint, you might look at your wrist and say, well, that's a pivot joint too. Well, yeah, it pivots this way, but it also pivots that way so that you can kind of go around in circles. So an ellipse is kind of a circular thing. It is going to move all over the place, your wrist will. Saddle joint is articulation between the first, that's your thumb, metacarpal, and the carpal bones. So it's just, that's all you need to know. Only saddle joint that you'll ever have a question, most likely ever have a question thrown at you, would be that one right there. So it's the radiocarpal joint of the first digit. And ball and socket gives you a lot of motion. So the ball is the femur, the head of the femur and the socket is what we refer to as the acetabulum. And all of the pelvic bones come together to create that socket portion, some ball and socket joint. We're going to talk about bony features, markings, the things that are going into the bone, things that are coming out of the bones. So sometimes some of these will fall into multiple categories. So I'll try to point those out. So you've got processes and projections that extend beyond the bone. So like this big glob of bone here, it extends out. So that would be a projection. Same thing here. Sometimes we refer to them as a process. But a depression would be a hollowed out area, like on the opposite end of the femur. We've got that right there. It's a great big hollowed out thing. So that is also what we'll see here in a bit as referred to as a fossa. So that's the a fossa, which is also a depression. You got fractures. It's just breaking a bone. We'll talk about those here in a bit. We'll talk about different types of breaks in bones. So a condyle is a rounded process at an articular end. So we've again got this femur, and down at the bottom, these two things are condyles. They articulate with the tibias so that you get that hinge. Okay, you don't actually have direct contact between the two. There's space in between the two, but that's a condyle, as opposed to an epicondyle is above it. So an epicondyle, the femoral epicondyles are here, and that's what you can feel on both sides of your knee if you reach down and push on both sides. So you have a coracoid process and a coronoid process, and they really should be different items on here because they're totally different. So a coracoid process is a beak-like process. So on your scapula, which is your shoulder blade, you've got these, it's about the size of your pinky finger sticking out just a little bit, maybe, I don't know, inch and a half out from the shoulder blade. And what that is ligamentous attachment points for your pectoralis major or minor. I don't remember which one, but anyway, it folds into there. So you kind of feel where that is, where you've got that soft indentation. If you kind of put your hand on your chest and you just kind of roll your hand out or push your hand out, where it sinks in right before it expands back out because of your humerus and your deltoid muscle, your coracoid process is inside of there. The coronoid process is a crown-like process. If we roll back up to the radial articulation here, this radial head, that's really essentially the coronoid process. So it's a crown-like process. Some people like to draw again more association and say, well, coronoid looks like Corona, right? Corona beer. Look at the cap on it, top on a Corona beer is brown. So coronoid process. And then you've got a crest, and a crest is a ridge-like process. And our most commonly referred to crest is going to be your iliac crest. So again, thinking about your Halloween decorations, you've got the top of the pelvic bones. That top would be what we refer to as the iliac crest. Epicondyle, we already talked about, that's above a condyle. A facet is an articular surface. It's just kind of flat and smooth. And where we see facet mainly is in the vertebra. So every vertebra has a projection on it. It comes off and it's relatively flat and it's at a bit of an angle. So and you really have two. You've got one coming off the inferior border, and then you've got one coming off the superior border. And those two come together to create a facet. So it's they come together to create what we refer to as we used to call it a facet joint. Now we call it a zygapophyseal joint. So zygapophyseal joint is where the two facets come together to articulate. So a hamulus is a hook-shaped process. The only place that you're going to hear about the hamulus or a hamulus most likely is in the wrist bones. We'll talk about that when we get to the wrist bones. The head, or a head, is the expanded portion. So the head of the femur, head of the humerus. A horn is a horn-like process. A line is a linear elevation. A malleolus or a malleolus, you may hear it referred to, is a club-shaped process. And where you find those are on your ankles. So those knots on either side of your ankle, on the inside and outside, that is your medial and lateral malleolus. You got a protuberance is just a projection. A spine is a sharp process. A styloid is a very sharp process. Sorry about that. It's a very sharp process, and you've got those throughout your body. So on this skull, what we have back here is the mastoid process. All right, so that's a real hard thing right behind your ear that kind of sticks down into your neck just a little bit. So what you're feeling there is that, but just in front of that is that sharp thing right there, that pointy, pokey thing. So that's a styloid process. You're more familiar with styloid process in your wrist, so that would be your ulnar styloid process. The ulna is on the medial side of the wrist, and that would be your ulnar styloid process. The trochanter, you have two of them. Well, you have four. You've got two on each femur. Is a large, rounded collection of bone. So again, in medicine, if you have something with a specific identifier, in a lot of cases you'll have one that's equally specific opposite identifier. So this is what we refer to as our greater trochanter. Our greater trochanter is on the lateral side of your proximal portion of your femur. And if you push real hard right on your hip and then you rotate your leg in and out, you can feel this thing start to move by. So that's your greater trochanter. Your lesser trochanter is right there. The line that runs in between them, we kind of passed over line pretty quickly, but the line that runs in between them is what we call the intertrochanteric line. So in a lot of your hip fractures, they'll fracture or break their hip right across that intertrochanteric line. A tubercle is a smaller, rounded, elevated process, and it is to the humerus what the trochanter is to the femur. So imagine this being a humerus. So what we would refer to that is the greater tubercle, and this will be the lesser tubercle. A tuberosity, again, is just a large, rounded, elevated process. A fissure is a cleft or a deep groove. A foramen is any kind of hole. So you've got a lot of different types of foramen as well. So you've got in the bottom of your skull, you've got where the brainstem passes through that great big hole right there. And that, in fact, is the name of that hole, is the big hole. Basically, it's the foramen magnum, so big hole. So your brainstem passes down through that, but you've also got, you saw all the holes in this thing. So I'm not going to name all of them, but some other ones that are, kind of interesting is you've got these, what we refer to as nutrient foramen above the eye, and I'm hoping that you can see these okay. Those are supposed to be little bitty holes above the eye. There's no one below the eye. And that's where blood vessels pass through. Another one that I hope you can see is I'm pointing it right at the camera, and I don't know that you can see it, but that is optic canal right there. So optic canal, it's more of a tube-shaped passage than what it is an actual hole, but you've got a lot of foramen. A fossa is a pit. A groove is just what it sounds like, a shallow linear channel. A meatus is that tube-like passage. So we tend to refer to the optic canal or the optic foramen as the optic canal. But what we refer to as a meatus more than anything else is where your ear is. So that hole where you receive sound that then transfers into the skull to the organs of hearing. You got your three bones and you got your tympanic membrane. That's what we refer to as the external, because it's on the outside, auditory, because it has to do with sound, meatus, because it's tube-like passage. So that's what we then will refer to it as is the EAM. So that's the external auditory meatus. Sometimes it'll be referred to as external acoustic meatus. So notch is just what it sounds like. A sinus is a recess or a groove or a cavity, a hollow place in a bone. And the purpose for a cavity uh, in a bone, a sinus in a bone, is a number of different things. One is to lighten the bone, but also in the paranasal cavities, it helps with sound resonance. And so that's what this square hole here is supposed to be demonstrating is frontal sinus. And inside, you should be able to see right here, that would be trying to demonstrate the sphenoid sinus. So you've got other sinuses that are in your facial bones here, and then other sinuses that are kind of behind your eyes a little bit. Plus, your mastoid process is really full of air cells that are also sinuses as well. So the other thing that they do is not the mastoids, but the paranasal sinuses. They lighten the skull by taking bony material out. They help with sound resonance. They help to determine what your voice sounds like. And they also warm the air, at least partially, before it gets down into your lungs. All right, so a sulcus is a furrow or a trench, and that's all of that. So our fracture types, also we can have fractures of different kinds that kind of blend or bleed into each other. So we've got closed fractures, and a closed fracture is just a fracture where the bone is not sticking through the skin. So a compound fracture is where it's sticking through the skin, and that's what we refer to as an open fracture. A non-displaced fracture is where the bone is broken, so you got it cracked, but the fragments, the portions of the bone are not separated. So if they're separated, then it's displaced. If they're not separated, it's non-displaced. And that determines how much work the ER doctor or the orthopedic surgeon has to put in to fix that bone. So if it's non-displaced, in a lot of cases, if it's an ankle fracture, they'll put you in a boot, see if it'll heal. If it's displaced just a little bit, I mean, technically, if it's not lined up better than that, it's a displaced fracture, right? But it may be so minimally displaced that the doctor will still not do anything with it except for cast it or splint it. But if it's broken and it's displaced badly enough so that the fragments are, completely not where they need to be, then you're looking at surgery or some sort of intervention. So within those classifications, we've got a lot of different types of fractures. So we'll go through these individually. You have compression fracture. A compression fracture is a fracture where the bone collapses. And compression fracture is going to sound an awful lot like impacted fracture, but an impacted fracture, in my experience, has been pretty specific to one type of bone, and that being the humerus, as opposed to a compression fracture, has been specific to vertebra. So if a patient has osteoporosis, and that's key in both of those cases, compression fracture is where the vertebra, which on x-ray looks like it's square, but it's not. And it collapses, and it may collapse on one side, make it kind of like a wedge, or it may collapse all the way across. So that's a compression fracture. Compound fracture, we already talked about, is an open fracture. That's where the bone is sticking through the skin. And a comminuted fracture is best described by lay people as being shattered. So if you ever heard somebody say, well, I shattered my ankle, I shattered my wrist, and I had to fix it or whatever, that's what they're referring to. But a comminuted fracture, by strictest definition, means that the bone is broken and there's three parts to it. So, if you had a broken bone, so it broke, and then you've got another piece of the bone somewhere else, you got a little shard of bone sticking off of it, then by definition, that's a comminuted fracture. So it's in three pieces, one bone in three pieces, comminuted fracture. But most of the time, even your doctors won't refer to a small piece of bone being broken off as comminuted. At least when they're just talking about it, they probably won't. In their reading the official record, they might. Childhood fractures, we're going to skip over for just a second. We're going to already talked about impacted fractures being a humeral fracture in my experience. And what happens is, let's say this is not a femur, but it's a humerus. And there's some similarities in appearance, but imagine a humerus. With a humerus, you don't have as big of a neck. The head doesn't stick way out like this. So visually and intellectually, take this and push it backwards. So it's pretty much straight in line with, but sticking off to the side. What happens with an impacted fracture is the neck of the humerus breaks and it slides up into the head of the humerus. So that's what an impacted fracture looks like. And it occurs when usually an older patient falls and they catch themselves, and they probably have some corresponding fractures somewhere else, maybe in the wrist, but the neck of the humerus breaks and it slides up into the head of the humerus. So a transverse fracture just goes straight across, as opposed to a spiral or oblique fracture. Kind of has a sharp edge to it. A spiral fracture kind of goes around the bone, as opposed to an oblique fracture just kind of goes at an angle. So with either one of those two, you're going to have sharp portions to it, and those are the type of fractures that are more common to be open fractures. So you may have let's say an oblique fracture, and sometimes they're sharp enough they'll refer to them as a bayonet fracture. And a bayonet's a kind of knife. That kind of knife you stick to the end of a gun, that's a bayonet. So they'll refer to it as bayonet fracture. So you may have a bayonet fracture that is also technically comminuted fracture because it's in three pieces or better, that is also a compound fracture because it's sticking through the skin. So you've got some overlap and some combinations there. And a simple fracture is just that. It's pretty simple. It maybe a linear fracture, transverse fracture would be a simple fracture. It's probably going to be non-displaced. Now, childhood fractures are a little bit different. So with a childhood fracture, what you may have is a situation where the bone bends, and with the bending of the bone, a sheet of paper, with the bending of the bone, you may get an incomplete fracture. So just like a green stick, what you may have is a fracture where one side of the bone did not break, right? So this side of the bone just bent, it didn't break completely, but what you've got is a fracture on the opposite side of the bone. So it's an incomplete fracture. Adult bones don't break like that. An adult bone, if you're going to break it on one side, you're going to break it all the way through. But kid bones can fracture where you've got fracture just on one side, kind of like a green stick. You go to break a stick off of a tree, and it's still a green limb, it won't break off very easy. And the other is what we refer to as a torus or a buccal fracture. And that's where we've got the bone, and it's kind of dramatic, where the bone, let's say this is the radius, the bone, you can follow the length of the bone and the appearance of the bone, but what you've got is this area where it kind of compressed and it kind of pushed the bone outward. So that's what we refer to as a torus or a buccal fracture. And those are fractures that are specific to kids. You don't see a buccal fracture in an adult. So that's osteology. If I hope this was helpful and kind of completes upper extremity. If you found it helpful at all, hit the thumbs up button. I would appreciate that. And if you're not a subscriber, I'd appreciate you subscribing to the page.